good evening. I am hoping, amongst hope, all things being equal, that I am with you and that you can hear me, and that I can see your comments and all this kind of stuff. So cross-post your live video to more pages. No, I don't want to do that. So I've got your comments open there, and I haven't got Cara to tell me whether I'm getting this right or not. So anyway, my life as usual is always a bit bizarre. My life as usual, as I said, is always a bit bizarre. So tonight I am coming to you from a barn in Devon, and up until today it's been a lovely, the weather's been great. However, it's decided now, as I'm going to do this, it's going to turn grey and blow a gale and give me some rain from outside. Anyway, I will do my best, and I've got some, as I said, I've got some questions. And next week, what I'm going to do is I'm going to go through some of the Bowen questions that we've got. So a sort of crossover of anatomy questions and crossover of some of the other sort of elements that we've got. So give me a second. I'm going to go into this and now share this desktop with this desktop. He says, hopefully, and this will come up. And I will give this caveat in terms of some of the questions I get asked sometimes are about specific things in relation to problems that people have, and I obviously can't answer them directly or specifically. The best thing I can do is to sort of give you a stab at it, and hopefully it will answer some of your questions to be general, and hopefully it'll be some things that you'll be able to cross over. Good, you can see loud and clear in South Africa. Isn't the internet an amazing thing? So some of the general questions I've got in relation to the sacroiliac joint and piriformis, and somebody sort of said the two areas for me would be SI joint and piriformis, and I wrote an article, actually, it's coming out in Massage World, and I'll put a post to, we'll put it as a blog post on the website. But I put it as a post where we have these syndromes, these SI joint syndromes and piriformis syndromes. And the bizarre thing is you can't have a syndrome unless you've got a name for the thing that you're syndroming, so piriformis. Piriformis is a bit disappointing when you go into it. It's sort of this little rather weedy muscle, and it's small and it doesn't do the thing that you think it does, and it's a sort of relatively weak rotator of the hip. And so the thing that you think is probably piriformis syndrome is under loads of other stuff like the glute max and glute medius, and I don't buy it as far as a syndrome is concerned. It doesn't make any sense. So yeah, and the same with the SI joint. A whole bunch of stuff is talked about the SI joint, and really the SI joint doesn't move the way that we think it does. You know, the osteopaths will go, oh, I can feel it moving, and I adjust it. It's not designed to move, and the amount of movement that it has is very, very tiny. Now, the exceptions will always be in cases like pregnancy and post-pregnancy. But generally speaking, where people have been diagnosed with SI joint dysfunction or SI joint imbalances and piriformis, it's generally going to be something else. And so I would be careful about those diagnoses. But you know, it's an interesting area. But think about SI joint as being a force-closed mechanism. It's there to transmit forces through it. It's not designed to sort of be lots of movement like a joint. It's given the word joint. But really, it's a sort of a closed joint, so it doesn't have the mobility, say, that a hip joint does, obviously. So, what role does fascia play in lymphatic flow? Remember, again, whenever we talk about fascia, and whenever we talk about things like, you know, that it's a connective tissue, and that all connective tissues have one thing in common, which is they're mostly inert, in as much as they're not cellular primarily. So all the connective tissues have this in common. So fascia is the same thing. It's an inert connective tissue. So that means it's a scaffolding. It's there to keep things open. It's there to keep things stiff and connected and rigid and have movement through it. So things like fascia will allow fluid movement through it. So it's vital in that respect. And once it gets scarred and blocked off, then you end up with a sort of a dam effect, if you like, of fluid not moving through it. So fascia plays a role in being part of the extracellular matrix. The clear is extracellular, and so lymph is everywhere, and lymphatics is, you know, the lymph nodes are everywhere, and so it's going to play a key point in terms of keeping things apart. But remember, there isn't one thing that you can talk about as far as being fascia is concerned. I have to remind you, by the way, that there is. I put something in the. I will try and put this in the box. If you go to this link here, he says, hopefully, I will find this company. It's Julian Baker, and there is a free webinar that you can all sign up for, which is a webinar on pain. I covered some of it last year. Let me go to this app.exu.com. So julianbaker.app. I'm just putting it in the chat there. So please go and sign up for that, and you get this free webinar. And I'll post that later on. So can a wonky pelvis, I love the word wonky, it's great. Can a wonky pelvis cause ankle pain? And again, I'm going to say that the position of the pelvis is going to be vital in terms of how we load and transfer movement through the body. So yes, a wonky ankle could cause imbalance through the pelvis, or the pelvis to operate and function in a way that may be out of its normal symmetry, and vice versa, that if the pelvis is tilted, you could find that the feet have to turn in a different direction. You have to get external rotation in order to compensate for that. The question is, which came first? Is it the ankle or the pelvis? And that's always the issue. You just don't know which is first. But certainly, and this is the issue that I have with anatomy, is that we tend not to think about these relationships. The external rotator of the foot, you turn your foot out, you're going to get a different way that the hip is loaded, or the pubic bone is loaded, and the forces that go through those joints are going to be different because you've loaded your foot. And we don't tend to talk about that in anatomy. We talk about what's attaching to it and what's not attaching to it, and that's always been my problem. Somebody says, not sure if you can help with this, but frozen shoulder. No, I can't. Can I help with it? Frozen shoulder. We'll talk a bit about shoulders in a minute, but again, the idea about frozen shoulder, it's called painful shoulder syndrome now, go figure. But the idea is that there's limitation in movement through the shoulder, and of course that can be caused by lots of things. And if we go back to the pelvis idea, you could end up with a pelvis that's in a different position, that's now not allowing movement through the shoulder because the opposite side of the pelvis would be unhappy with that. So frozen shoulder in and of itself, I'm not buying a localized and regionalized thing. There's a region. So lateral flexion of the neck, rotation of the head and neck. These are all factors that are going to play into the shoulder. And somebody asked also, do we have dissections? And yes, I will be looking at a detailed dissection and movement of the shoulder, particularly supraspinatus and the brachialis as well, which is really tight across the top of the shoulder. So the supraspinatus is a sort of a bit of a forgotten area of the shoulder. But again, having a look at that neck, if you've got somebody with rotational neck, limitation of the neck, lateral flexion, rotation, and they're presenting with a shoulder that isn't moving through abduction, abduction or adduction, then this is what you're looking at. And also, the moment you start to see over movement through the shoulder with an arm, the moment you lift your arm up, if you're you shouldn't really see much movement through the scap or the shoulder here until you sort of get to about, let me move my chair back. Up for the cat, until you get to sort of up to here. But the moment you start to see people doing this, then there's a good indication that they're overly using their upper body. And this is a very interesting thing. I've come across this a lot over the years, that you have people that have lower back pain or knee pain, particularly where there's a lot of physical loading involved. And perhaps they've gone back to work or back to that movement or back to that sport too soon, and so they've started to use their upper body in a way to protect their lower body. Perhaps there's fear of the pain around that as well, and that's not uncommon. And so you start to see this action going on, and suddenly before you know it, you've got overcontraction through the traps, and hey presto, it's there. So Brenda says, I'm sure her joint was out, went to an osteo, and they put it back in. It wasn't out, and unless it left a message saying gone out, be back in 5 minutes, which I don't think it probably did. But so yeah, I question some of the terminology that we have that's around that. So what does it mean by out? But again, it's a deeply held religious belief of the osteopaths about the SI joint, which doesn't sort of bear out as far as the evidence is concerned. So. Too much lunges in sun salutes in yoga. Well, okay, you got to go easy with those sun salutes. Only 20 a day. So the acute shoulder, somebody saying their friend has been treating the acute shoulder with massage oils and cupping and improved quickly. And there's a question about steroid injections and has lost movement. And this lady's mother is in her mid-80s, keeps very active and accepts the situation, but it's difficult to put the arm behind the back, so to catch her behind her to catch her foot. So she's in half Dhanurasana. So I'm standing as a runner's thigh stretch. Do I have any insights? Difficult to put her arm behind her back to catch her foot. So this is external rotation that's going on here. So then we can look at position of the head, we can look at the pecs, and we can look even down into the opposite hip again, and the abdominal. So don't just think about shoulder. And also restoring function, lots of different ranges, and to limit the stretching that goes on. There's a video I've done on stretching versus loading, and it's a really interesting subject, and sometimes people will overly stretch a structure to try and get it moving when actually the opposite is required. So you know, in terms of injury or pain, I would say stop stretching it if it's something that you stretch. It's a tricky thing, but you know, it's a weird situation that we have as far as stretching is concerned. So this is interesting. Somebody has sort of said, I would love to know anatomically why when my gut is inflamed, my pelvis rotates forward on the right and then gives me sciatic pain down the left. I don't know. So this person has been diagnosed as having SIFO, which is small intestinal fungal overgrowth. So SIFO means you've got a lot of excessive fungal organisms in the small intestine, and it's associated with a lot of gastrointestinal systems. It's a sort of a catch-all phrase, if you like. So candidiasis and this kind of stuff. So the overgrowth of the fungus in the small intestine can be blamed for a lot of the unexplained symptoms that somebody might have in the gastrointestinal tract. So as I said, it's a sort of catch-all for that. When your gut is inflamed, the whole question has a lot of assumptions in it, and this is what I mean. So how do we know that it's only when the gut is inflamed? And the pelvis is rotation on the right, and we don't know what the symptoms are of the SIFO. So the inflammation of the gut is giving some symptoms, and then the position of the pelvis is noted. So the forward rotation of the pelvis. It could be that there's that feels better. We'll always move away from wherever we have pain. That's what we'll do. You know, if we sprain our ankle, we'll limp in order to relieve the pain. We won't walk on the pain. I don't know, but again, if the pelvis is moving in protection of the pain, then that could give sciatic type symptoms down the leg. We'll come to sciatic type pain in a minute. And it would be to do probably with the gluteal nerve rather than which is branch of the sciatic nerve, but more to do with gluteal nerve than anything else. Without seeing it, I don't know, without getting a bit more of a history, but certainly when you have painful guts or inflammation through the abdominal or intestinal area, then you're going to move away from that pain. You're going to adjust yourself. You're going to get yourself, you know, if you've ever had, I had this weird thing yesterday. I've been sort of throwing a rugby ball, and I got this weird sort of banded chest pain, and I was like, that's interesting. And you always like getting pain and finding where it's interesting, and it was slightly catching my breath. And so you move either in or out or away from that pain, and you do it subconsciously, and I think that perhaps that's what's going on with that. Next question is, can lymphatic congestion, in this case in the arms, cause pain that is intense and sharp and feels more like ligament pain? I suppose so. Yeah, if you've got pressure in an area, then yeah, you can put pressure on nerve endings, you can put pressure on anything. You know, that's the thing is that a build-up of tension or pressure may well lead to symptoms like pain, that feels like ligament pain within a joint. And remember, we're talking about within a joint here. So potentially, yes, especially if the lymphatic congestion is caused by another inflammatory response that we might see in a joint. that may cause swelling. So for example, rheumatoid arthritis, that may be an immune system response that's creating an inflammatory response that's causing swelling. That's not necessarily lymphatic congestion, but there is some kind of swelling going on in the area, and that would give, you know, pain, and that would feel, whether it feels like ligament pain is down to how you interpret the pain or what you've had before. So again, it's very subjective. Pain is always subjective, but go back and have a little look at the pain webinar, and I'll just put that one in again because I've been told to. I get my instructions these days, and if I don't do it, there we go. Oh, that doesn't seem right. Anyway, okay, let me see if I can copy this as well. Copy, link, copy. Okay, let's try this again. Oh, I did come up there anyway. There we go. Oh, you're having a chat about moving to Ireland. That's fine. So it's an interesting question. What's the best posture for us to be in as therapists when treating clients? What do we need to remember to avoid injury? And it's a really good question, because I think the thing is to avoid repetitive positions where you are overly loading for any period of time without introducing movement to it. So being aware of your own movement, and where, you know, if you're in a certain position, I know some people that I know that were doing craniosacral would find that they would be in a certain position for a length of time, and would find that very loaded and stressful in that position. But so from a Bowen perspective, I'm very rarely in any one position for any length of time, because I'm, you know, out the room or treating somebody else half the time. So I think the thing is be aware of where you feel stiff, or where you feel that you're often in the same position, and try and vary that, whether it be the height of the table, even slightly, or whether it be the position that you get yourself into. So although you're training into that position, you also want to make sure that you're not training in a position that's overly loading you. And you know, the body can take quite a lot of load. It's just a case of making sure that you feel that, you know, if your head's forward, that you can take a break, take a step back and move. So the best position, it depends on what you're doing. If you're, you know, a reflexologist and you're down here with feet, then you want to adjust the position of your hands and your client so that you're moving around. So if you're doing the same thing day in, day out, and you're not changing the position, then you might want to think about that. So plantar fasciitis, you'd like to talk about more plantar fascia. So fasciitis, and again, this is a troublesome area. So the plantar aponeurosis, if you go into an anatomy book and you look at the first layer of the foot, the first anatomical layer of the foot, is this deep, long, wide, white structure that's referred to as plantar aponeurosis, which is also referred to as the plantar fascia. Now, when I talk about plantar fascia, I don't talk about plantar aponeurosis. I talk about the tissue that is directly between the skin and the plantar aponeurosis, which is a fat pad, which is held in place, like all the fat tissues are, the fatty tissues are, by collagen fibers. Now, the collagen fibers that we have in the palm of our hand, sort of palmar fascia, and the collagen fibers that we have in the sole of the foot, the plantar fascia, are a lot more closely and tightly arranged. So this means that these fibers go through from the skin, and they directly blend and become the fascia of the deep fascia of the foot, the plantar aponeurosis. So I would be starting from a much more surface perspective, and I'd be looking at where that arrangement is changed all the way around through the heel, both sides of the heel, and up into the calf. So I don't accept that plantar fasciitis is a condition of the sole of the foot. It doesn't make any sense. It doesn't add up. And I've never seen a plantar fasciitis where there is you get something called like Mawson's neuroma, even, where there isn't some kind of tensional relay issue that's going on round the Achilles and into plantaris, up into the knee, you name it. It's a continuous structure that goes through it, and it's very poorly described, and it's very poorly discussed. Even around the back of the heel, you get this sort of heel pad and that tendinous lining that's going into the Achilles. It's just not considered. It's like, there's your foot pain, that's what it is, and we look at that. So Yeah, so I would be looking a lot more up around the back of the heel into the Achilles, and there's a little bit of kit that joins up from the Achilles called the plantaris, and it's very, again, poorly described. People often think it's a nerve in dissection, but that starts from the medial side of the Achilles. You won't know whether you've got one or not. Apparently it's absent as a normal variation. I've never seen one that's absent. And it goes behind the gastrocs, between the gastrocs and the soleus, crosses over the back of the leg and ends up on the outside, on the lateral side of the femur. And the fascia of it continues into the external tissues and the fibres of the thing that you call the iliotibial band. So it's very interesting. And working it and thinking of that as a continuous long structure has a big impact on things like plantar fasciitis. So have a little look. And just rotating the foot, simply sitting and rotating, sitting down and moving the foot through round and round, and in both directions. For so many people, it's really hard. And then starting to move through a figure of 8, that people can't do it. They can't get flexion into their foot. Of course, that's going to load at a certain point. So the same thing goes for this movement and rotation around it. Look up, look into calf, look at where there may be any imbalances through the feet. Where are the feet turning in, inverting, everting? Are they doing it symmetrically? Are they doing it the same? So, are the both feet turning in? Well, that's fine. Are both feet turning out? That's fine. But if you get one that's turning in or one that's inverting and the other isn't, have a little look at the shoes. Do the shoes, on the underside of the heels, are the heels wearing down evenly? These are all the things, the clues to look out for in the assessment, to look and say, well, what's going on here? What's being loaded? I mean, we all have a one foot that's our leading foot, but how much of that is going to be creating an overwork, if you like? Alvina says she's not the only one who thinks this way. No, I don't know how you think, Alvina, but be thinking about how much you hate other people camping next to you sometimes. Oh, this is a good question. Why do some people suddenly get affected by scoliosis? And you'd love to think that soft tissue work could help, but sometimes things happen so quickly and organs are being affected, particularly serious, surgeons seem to move in ultra fast. There's a lot of speculation about scoliosis, why it develops, and how it develops so quickly, and really we just don't know. I mean, there's theories that it's a ticking time bomb, that it's being developed from inside the womb. That early there's a book called The Endless Web, which talks about it by somebody in shorts, can't remember. So it really is just very interesting, and perhaps we don't catch it as early as we could. The signs of it are there, and maybe earlier. It's just a mystery. So mild scoliosis, I think we can get good results with some soft tissue work. I know Bowen's had some good results with relatively mild scoliosis, but some of those really big curvatures, then no, I don't think we're going to get that in short order. I just don't know. But again, lots of theories out there, lots of ideas, but I don't think we've demonstrated clearly why it happens and how it develops. Question: how much space can be actually created in the spine? We're taller in the morning, the evening, etc. What's the real measurement that can be achieved between vertebrae through movement? None. You don't want space in your spine. There is no requirement for space between vertebrae. The vertebrae are held intact, and they are wrapped strongly with ligament and tissue and connective tissue, anterior, posterior, longitudinal ligaments that hold it in place. And so the space that you want between your spine is zero. It's a closed system. And if you have space between your vertebrae, then you have the potential for there to be pressures that are going to push the pulpus out, and the central pulpus out. Now, the reason we're slightly taller in the morning than we are in the evening is because you're going to get, there's a sponginess to us, not just in the spine, but also in the hip joint, in the knee joint, in our connective tissues. So all the way through the body, it's not just that we're taller in the morning and the evening because because of space, it's because of hydration and because of compression that's gone on through the day. But you don't want space between your vertebrae. I don't know where this idea comes from that you have to open up your vertebrae. You're looking at movement, and a spinal column is held in place. And you go into a spinal column and you want to dissect it, then you're going in with hammers and chisels and saws. You're not going in with fingers. It's not a soft piece of tissue to dissect ever. Even where you see gnarly spines and you see bulges and discs, they're not soft bulges. They are hard, bony bulges. So don't look for space in between vertebrae. What you're looking for, if anything, is you're looking for there to be effective elastic movement along the supraspinous ligament and the ligamentum flavum, the yellow ligament, and this is the where you find elastin and reticulin structures that allow movement, flexion, extension, and the spine to be mobile. But that's not the same as space. So creating space is not a desirable thing in the spine. Visceral fat versus subcutaneous fat. Can you tell the difference on someone with a large belly if it's in the viscera or under the skin? Are there different dangers and different ways to deal with it? Yes, so there's quite a lot of literature that talks about visceral fat and how dangerous it is. And when you dissect, you get somebody on the table and you can't really tell. You might look at them and see they're quite big, but then you take the abdominal tissue out and you've only got this sort of small amount of fat between the skin, the deep fascia of the abdomen, and all the rest is in the belly. And even then you get in there and there isn't a huge amount of fat that's sitting around on the outside, say in the greater omentum, but is sitting in the sort of mesocolon, in the space around the small intestine particularly. So that's where you tend to see that fat loaded. And there's quite a lot of literature on the dangers of visceral fat. And as far as dealing with it is concerned, then really we're talking about lifestyle changes. There's not much you're going to be able to do as far as the treatment is concerned. And as far as where it's stored, well, again, the body's going to store it there because that's where it's genetically predisposed to be storing it. You can't change it. You can't direct your fat to be put onto somewhere, and you can't direct your fat to be taken off from somewhere. You can't burn belly fat. You can't, put your fat on your hips and choose to do it. That's not how it works. It's if somebody's got a big belly, you can pick that skin up and you can feel how thick that tissue is, and you've got the big spare tires. And I did notice in the USA, you do have a lot of this sort of tire that goes around, and I'm going to say that's what I call a sugar tire, and it's quite unique to some of the people that we see in the obesity type of obesity you see in the USA. You don't tend to see it in the UK in the same way, or the rest of Europe, but it's coming, and I think it's probably things like high fructose corn syrup and the amount of sugar that's loaded into a lot of the food out there. It's very sweet. So again, that's my experience, but you see it everywhere, and it's quite a tire. And when you see that type of fat and you dissect it, it tends to be much less fibrous than some of the normal adipose superficial fascia that you'll see in other areas around the body, around people that have it. So again, it's laid down really quickly, and so you haven't got the same level of fiber that's built up around it. Again, how to deal with it, you just gotta, it's just chemistry and enzymes and burning it off, really. There's not much else to do it. So somebody's asked about the raising a newborn. You're having a newborn, congratulations. I hope you're sleeping. This is a really good functional one. I've seen this a few times. Developed stabbing pain in the front top of the right shoulder, and in addition to a neck sprain which radiates from the base of the skull to the scapula. So it's a really interesting one, particularly with carrying a baby around. Now, the newborn obviously hasn't quite got there yet, but there will be a tendency, if you're breastfeeding, to feed one side or the other. And the predominance for women, funnily enough, and it's been quite well studied, is even though women will claim to be breastfeeding equally on both breasts, the tendency is for the left breast to be heavily favoured. And the reason being is because baby tends to feel better on the left breast, as the heartbeat is closer, and so the tendency here will be to do this. So the rotation will come in, there's the rotation, and the head is there. And you're looking down and you're moving and you're stroking, you're doing that however many times a day, and you key into any other injury or issue that you've had going on, and hey presto, there it's going to be. Later on, what tends to happen is you tend to see this thing going on where you've got a toddler on the old hip, and you stick your hip up, and you lift your shoulder up, and you're carrying that baby around on your hip, and hey presto, the elevation is there as well. So combined with that, the two of them can happen. So look out, have a little look around when you see people carrying babies around or breastfeeding. Have I seen this picture? Yes, so Tricia talks about the gastrocs. Yes, I have seen that picture. That's a picture of a cyclist, and it's yeah. Cheers, Brenda. Catch you with the rest of this. It'll be recorded. That's a picture of a cyclist, and he's a long distance cyclist, and he was training. I think he's also had some issues in the past in relation to eating disorders, and so from what I remember. But yeah, it's a very, very well known. It's not retouched. It is how it was. I sort of saw that picture and thought it was. The thing is, in a lot of muscle development, you get massively dehydrated. So a lot of the bodybuilders will dehydrate themselves in order to get definition, and that's kind of what's happening. This is from a cyclist. So there you go. So shoulder impingements, do you have any footage of dissections of shoulders in the detail of rotator cuff? I'm going to say one thing which is really interesting. Whenever you have a cadaver, so I've over the years dealt with cadavers and donors that have kindly left their bodies, and so I end up having to rotate the hips and get them loosened up, and the knees, and so you quite often see restriction through the knees and the hips and various other joints, but you never see it with a shoulder. Never do you not see a shoulder move all the way around. So you wonder what's going on in life if you've got this amount of movement through the shoulder in death. And so these impingements, I'm going to say, a lot of the time I think are functional and postural. The position of the head, the tensional load through the rest of the scap, the slight retraction of the shoulder blades. These are all contributing factors to how a shoulder is going to be loaded. Scarring, if you've broken a collarbone, say like I have, it may impact on it over a period of time. But generally speaking, I think shoulders are massively postural and functional in terms of how they sort of get impinged, and they're generally coming from somewhere else. And we don't tend to look at this enough from, say, even a rectus spinae perspective, where you've got structures that are going right up into the back of the head. But yeah, I have got pictures of the shoulder, but again, I'm wary about just saying here's a shoulder, because as you know, it's not really a thing. The shoulder has to move around on an external structure, and so all of those tissues that are part of that external structure, that sort of body armor that you can pick up and put down, which will include the shoulders on the top of the head, all have to be thought of, particularly things like thoracolumbar fascia blending into the lower spine. So if you're not dealing with that, then you're not really dealing with the shoulder, as far as I'm concerned. The fascial connection between the lumbar spine and the gastrocnemius, a trigger point connection. Yeah, there may well be a trigger point connection. I don't know. I don't really fully understand trigger points. They have been explained to me. I've spent time with a very interesting chap from Washington who's worked on a lot of trigger points, the big trigger point man. And yeah, as far as a fascial connection is concerned, well, you've got a fascial connection everywhere, because that's what connective tissue is. It's a body-wide connective tissue, whether it be skin, superficial fascia, or deep fascia. And so the gastrocs going up to the lumbar spine will be predominantly something, say, through fascia lata that you could take, that's going to come down the leg, wrapping around. Going to be the iliotibial band is going to be part of that, so the so-called iliotibial band, and all of that fascial bag that sits across the back of the gastrocs is going to be blended into it. And then again, you've got, as the gastrocs come down and they join up with soleus and become the Achilles and the plantar fascia, and then go round under the side of the foot, well, you've got lots of different connections up through that. That's going to go up into, say, the lateral side of the foot as far as fibularis is concerned. So I wouldn't pin one down. There isn't a straight line, I mean, you might stretch and feel it, but there aren't any lines in the body. And the anatomy trains is great because it helps us to visualize the body, but they are imaginary lines. They don't exist. So the strain will be depending on where you're going to load it. So you could take it through the sacrum, you could take it through the pubis, you could take it through the glutes, but that connection is there. It's a structural and physical connection. It's just a case of how you interpret that from somebody's function, and function is always going to be an individual component of the individual. So, author of The Endless Web, somebody called, I can't remember, Schultz is the name of The Endless Web, it's on my bookshelf. Question, when palpating knees and a patella of one or both feel cemented into place, why is this and where is it affecting out from there? Well, again, the patella is there to be able to stabilize the movement and the load that's going through it. So, for example, vastus medialis is going to hold the patella from dislocating. So the patella shouldn't be cemented in place, and really mobilizing it and just giving it a good wiggle is going to make a big difference. Why is it? I don't know. Again, it's going to be functional. It's going to be because somebody's hurt it or they've landed on it, or in some instances with knee replacements they're cemented into place. Or there isn't one, you just, too much infection in the knees and you cement the legs so they don't, or they bend very little. I'm sure they do it very much these days. But and again, the question that is about, where is it affecting out from there? I just don't know. Again, it's going to depend on, looking at where that load is. And if the patella isn't moving, there's going to be a compensation for it. If the arm isn't moving, if I can't lift my arm up, then I'll be using it differently. I'll bend forwards to pick something up, and I'll use my head in a different way. So a lot depends on what that person is doing from there, really. So again, hard to say. The activity of intrinsic foot muscles, ankle stability, hip knee alignment. Bear in mind, if you just think about the flexors, the extensor digitorum and extensor hallucis longus, the extensors of the toes, go almost up to the knee. You could say that they are knee muscles. So we talk about the foot. There aren't any foot muscles. There are very, very few major foot muscles apart from these tiny sort of lumbricals in the toes that are just in the foot. All the major structures as far as the foot are concerned are going to come around the back of the ankle or around up through the front. Think of Tom, Dick and Harry, tibialis, digitorum and hallux. And these are both front and back, and these are all structures of the lower limb that are blending down into the foot. And fibularis particularly is one that I'm very, very fond of. And fibularis, if you imagine this is the foot, I should have put my foot up. Coming from the fibula on the lateral side, and it's going down around the back of that malleolus, and you've got fibularis brevis, which stops on the outside, but longus goes all the way across to the big toe, and its job is to sort of allow this movement, this inversion of the foot, and that's where it's sitting up, is right onto the fibula, and it's part of these structures that we're going to call the fascia lata and the iliotibial band. So it's all part of that tissue. So you've really got to look around, knees, ankles, hips. Those are three major joints, and they are connected very strongly with both muscle and connective tissue across the joints, around the joints, and through the joints. And so you can't ever assess one without the other. They're part of a trifecta. They don't move without each other, and they compensate if they do. So Endless Web, Louis Schultz and Robbie Felt. That's it. If your feet always hurt first and get tired running or even on the golf course, again, that rotation is a big deal, because you're not just rotating your foot, you are rotating through your knee, your fibularis, and I would also say that if you're getting calf pain, or then that's going to be part of it as well. So a gentle squash ball or a tennis ball on the underside of the feet rolling around, nothing that's going to hurt. You don't need to go mad and start to get those spiky balls on the underside of your feet so you're screaming. But you do what you like, I don't care. You want to hurt yourself, then go for your life. Movement through the foot and conscious barefoot walking. A number of times I've got people going, just get your shoes and socks off and walk up and down the hallway and just feel how your feet connect to the floor, and just getting people to be conscious of how their feet connect to the floor is like, and now change the position and feel what happens through your hip and feel what happens through your back. People with back pain, you get them to move their feet in different ways and their back pain goes away. It's absolutely remarkable how being conscious of what your feet are actually doing changes the way that your head position is, and it's not hard to do. I remember going skiing with an ex and we went through 3 pairs of boots because my everything hurts, and she was and skiing in this sort of crunched up way, and in the end I said, it's not your boots, it's the fact that you're clenching your toes, and that's what's hurting, and so therefore your back hurts and your knee hurts and you can't turn and you can't get anything going on. So it's just that's what was going on. Nothing to do with the boots. You could go through 50 pairs of boots and have them custom made for you, but when you're clenching your toes like that, it's always going to affect the way that the rest of your body and your lower back moves. So if you're not sure, get on a pair of skis, or don't. So again, Achilles tendons, we mentioned that, and somebody's talking about so it is an important structure, and they're not really looked at. A lot of stuff talk about snapping them, and somebody damaged their Achilles very badly and can't stop work, and the work involves 28 to 30,000 steps a day, but this person doesn't remember how it was damaged. It just suddenly hurt. And the question is, which integral tissue, muscles and tendons could we treat to aid the healing process? And I go back to what I was saying before, that they're all integral. The idea of the Achilles is that it's there not just as a transfer of load, as transfer of force, but a distribution of that force in lots of different directions. I did a section a few years ago where by accident we sort of snapped the Achilles, and when we folded it back, what you see is this fan of the Achilles, where the load is being dispersed not just clearly outwards but around and upwards. And I'm reminded of if you go to a cathedral and you see that sort of fan vaulting, you see the pillars going up and you see this fan vaulting going into the ceiling, and that's really what it reminds me of this. And I think we don't think about how widely we have to distribute our load, and how we have to distribute the force, particularly through the feet. Jumping and running is where we're going to have to make sure that force is loaded and distributed. So just simply mobilizing the Achilles, and I think that's what plantaris is. I think it's like the strings of a kite that are holding things in place, that are moving things around like that. And so gentle mobilization, we don't have to go mad, but again, rotation, making sure that if you get hold of the feet, move them, rotate them, walk around on them, and feel what's happening. And as you walk through plantar flexion, elderly people tend to stop walking through the plantar flexion. They tend to go into a bit more of a stiffer walk because they're coming forward, so they feel more unstable, less plantar flexion, less mobility, and so therefore excuse me, you end up with more stiffness and less mobility, and it's a vicious cycle. So lots of plantar flexion, lots of rotation, and lots of focus on how those feet move around. It's a really big deal. And then finally the question is, are Indian head massages so successful due to connective tissue relationships? It's a loaded question, because I don't know if they're successful, and if they're successful, what are they successful for? How do we define success? What we mean by success. People like them, or they've cured cancer, or I don't know. I think it begs the question about a lot of therapies. Why do therapies do what they do? And I would say the primary thing that therapists do is they touch people. And the idea of being touched for a human is vitally important. And when you touch another person, they are connected, they feel something, and that connection, that way of feeling is vitally important. So somebody comes and they have the thing that they like, and in the process they are being touched, then all bets are off as far as the outcomes are concerned. I'm not saying it's placebo, because placebo, well, I'm not saying it's not placebo. I'm saying that it's very hard to overcome a placebo in terms of pharmaceuticals. That's what they have to test it, double-blind, randomized controlled trials, double-blinded, where the person giving the drug doesn't know what it is, and the person receiving the drug doesn't know whether they're getting an active ingredient or not. And then you have a control. So it's very, very hard to beat placebos at those trial stages. And so I don't have a problem with the idea of placebo, the concept of placebo, the idea that somebody feels better because something has happened to them. Is that placebo, or is that an active ingredient? And I think that the problem that we have is that you know, touch has been eliminated from our lexicon of medicine. We don't do it. You know, everybody's frightened of it because it's been sexualized and it's been made suspicious, and we fear touch. And yet it's not addictive. It overcomes infection rates like they wouldn't believe. It speeds up recovery. It reduces revisions of surgery. Every single study that we've got tells us that touch is probably, you know, the missing link, and yet we don't really talk about it. And again, from a study of you know, neural anatomy and neurology, the idea of sensory input is really important, because sensory input, pain, that's what pain is. Pain is an outward signal. It's coming from the brain, and there's ways of gating it, and one of the ways of gating it is touch. You know, if we touch somebody and your child falls over, we don't rush off and give them medication or start deep tissue work. We rub it, or we kiss it better, and we make them feel better. We hear that expression that says, oh, well, you know, when you've seen the doctor, you'll feel better. And we know that that is the case. So why do we fear this idea of touch so much? I don't know. Why do we not have it? There isn't a system, westernized medical system where touch is our primary aspect. You know, it's very much hands off. So I don't know. Is Indian head massage successful in that respect? What are the trials on it? What's the literature on it? I really don't know. And Claire says mood stroke Bowen. I don't know. What does that mean, Claire? I don't really understand. So yeah, it's really one of those things that there's a lot of questions in here. They're great questions. I love getting questions. Please, I'm just trying to do as much as I can and have a holiday. And every day I wake up and I think of something else that I need to talk about and make videos on. And I've been loving the questions that come. And my feeling is that sometimes what we need is a little bit more confidence in our therapy. Sometimes the bit of real science is missing, the bit of real anatomy is missing, and that's where I'm coming to, is that we don't need to necessarily expand a huge amount, but we need to know a bit about connective tissue and fascia. We need to know about some of the major areas of the body and how they are strung together, not, you know, how a hip joint works or a pelvis works. We can study that anywhere, but, you know, my shtick is about saying, well, you know, when you have a foot and you externally rotate it, how is that connected up and how might that affect a pelvis? And that's not really something that is very widely discussed or talked about. So that's really where my sort of problem solving thing about. And again, things like skin and superficial fascia. So, you know, I'm really keen on getting that stuff out there. So thank you very much for joining me. Thank you for all your questions. Sorry I was a little bit late getting going. I had to find a barn out of shelter. I was hoping to do it from down in my motorhome and where the awning was, because it was beautiful last night. But unfortunately tonight the weather has turned in, so I had to sort of decamp to a barn and thinking fundamental. I think, Claire, we're going to have to come back to that in terms of, yeah, fundamental mood, not emotion. Yeah, I would agree that in terms of what we're doing when we touch people is to change the communication between central nervous system and autonomic nervous system. That's a subject for another time. And the emotion that we experience that creates a physical change in us, I think that's a really interesting subject, and it's something I'm taught a lot about on and I've written a bit more on recently, so we'll come back to that. That's a really interesting subject. So please join me next week. I'm going to be doing more questions about we've got some questions that are specific about Bowen, so I'm going to be doing that, and this will get loaded up as well. I've also been videoing this, so depending on what the recording's like, we might just sort of edit this down a little bit and load this back up. But please share it, look out. I've been putting loads of videos up on YouTube recently, so go and find me, Julian Baker, Bowen Technique on functional anatomy on YouTube. There's loads of stuff on that. Please leave me comments. This is the new normal. You have to comment and you have to like me and subscribe, and I have to say that. And if I don't say that, people say, make sure you ask people to like and subscribe. And so thank you, Anne, for that comment about the lengthening and gapping. It's a visual thing, and about, you know, extension and gapping. So it's a really good point. I am going to stop there now. Thank you so much, and look out for me if you're on Clubhouse as well. Occasionally I do some stuff on Clubhouse, but please check out the videos on YouTube. Leave some comments here, any questions that you've got coming on. Please share the videos widely as much as you possibly can. It all helps. And then the ultimate goal in the next 18 months, if we get what I need to get going, is we'll end up with our own specific dissection lab, which will investigate the touch therapies that we're doing and the connective tissue, and that's our goal, is to have that lab working 6-7 days a week just to look at connective tissue and the effects of it. So we just got to kind of make some money out of it first. So please do share widely, and subscribe, and look out for stuff on YouTube and Facebook as well. And always bring your questions in. I value and appreciate them. Thanks very much, and see you next time. Bye for now. Thanks, guys. Thank you, Priscilla. Thanks, Trevor. Thank you all for your comments in the comment section. Thank you, Beth.